Good, then we move to our next session, and now that the next topic is about nuclear medicine. We all know a lot of different opportunities or disciplines in medicine, but also in oncology. So we all know about diagnostics and radiology, and we also know about surgery and oncology and a lot of pathology, different disciplines. But many patient advocates, that's our experience, they really don't know less about nuclear medicine. And nuclear medicine is becoming more and more important during the last years, not only for diagnostics, but also for therapy. And you might have heard, maybe some of you heard about PET-CT. That's part of nuclear medicine, but also there are much more issues that could be also relevant for our patients, but also our field of sarcomas. Okay, and so I hand over to Wolfgang Pendler. He's a professor in Essen. And he's working in the nuclear department there, medicine, together with Professor Hermann. And they are doing a lot of work in nuclear medicine, driving nuclear medicine forward also in Germany. Welcome.
Thank you very much. And moving on, after your excellent introductory words to the field, I think my job over the next 45 minutes will be to talk to you about the basics of nuclear medicine. I just want you to understand what the field of nuclear medicine is. No specifics, but what this field can do for cancer care, imaging and treatment. We're going to look at some basics of sarcoma imaging. So what nuclear medicine can contribute to seek cancer, to characterize cancer. Then we look at two current applications, which is FDG PET-CT imaging to characterize sarcoma, for sarcoma grading and for monitoring response to treatment. And then the last part will be looking into potential future applications. So new developments, something which is currently in the translational pipeline, but might be important in the future, which is here as an example, the FAP-directed imaging and radioligand therapy of sarcoma. What can we contribute to sarcoma care? And the major field of nuclear medicine is now contributing service using radioactive medications to seek, to detect, and to treat cancer. This is like more than 80 or 90% of our clinical workload that we do daily, and also most of the research that we do. So we inject medications that behave like typical medication, but their mode of action is through radioactivity, which acts inside the body. And then if you use the right radioactivity, we can do excellent images, as you can see here. We can obtain a whole body image and see the tumor. We can detect where the tumor is and how this tumor changes under treatment. How does this work? And I just want to show you the one most important example of how we do imaging, which is based on glucose, so the basic form of sugar. This basic form of sugar is being taken and it's being modified on one part of the sugar. Most of the sugar stays the same, but one part, the C2, is being modified. So we exchange one group, the oxide group, with an F18, which is radioactive. And this radioactive sugar is called FDG, so fluorodeoxyglucose, but it still behaves like the normal glucose. You can take it up, you can use this as an IV injected medication. It's been taken up into the body, into organs, into cells, similar as the normal glucose. So what can we do with it? We can image the glucose metabolism inside the body using this radioactive medication. So this is a combination of a normal biologic medication and a radioactive carrier, which is together called the radiopharmaceutical. This is something we need. And this still keeps the normal behavior of our medication, the normal behavior of glucose in this case. It's retained inside the body, it stays in there so we can make images, and it delivers radiation for imaging in this case, or in other cases, those medications deliver radiation for treatment. And the typical terms that you might have heard for the clinic is scintigraphy or bone scintigraphy, or the PET-CT imaging, hybrid imaging, or PET-MRI, PET-MRT imaging of cancer. These are typical terms that are being used and methods that are being used. And these are imaging modalities that are being performed and offered by nuclear medicine in a high volume for cancer care and patient care. Just some examples on the left side: bone scan imaging, bone imaging to see bone diseases or to see tumor inside the bone; lung imaging, thyroid imaging to see the function of these organs, function of lung, function of the thyroid; heart imaging, kidney imaging. All these are called scans usually, so kidney scan, bone scan, thyroid scan, because we can see on these images how the organs work, how they function, or how they dysfunction. And then on the right side, which is most important for sarcoma care, is tumor imaging, using FDG PET-CT to seek the tumor inside the body. Before we go into PET-CT, I just wanted to show one example of how scintigraphy can work and help in patient care. And scintigraphy works in this case through injection of something that behaves like calcium. It's called technetium bisphosphonate, and it's called a bone seeker. So it behaves like the normal calcium. It's been taken up into the body or into the bone like normal calcium. We do scans 3 hours after this injection, and this is one of the bone scans that we can see here. And how does this work? How can we use those images? Of course, an osteosarcoma will behave similarly as bone tissue because it originates from bone tissue. It takes up this radioactivity, and then on the scan we can see the bone sarcoma on the lower leg, but we can also see deposits of the bone sarcoma inside the lung that should not be there, but we can, on this scan, on these images, we can see it and detect, and we can guide treatment using the scan results. Going into positron emission tomography, which is probably most often performed for sarcoma imaging and for detecting sarcoma in a treatment algorithm. And again, this is a combination of two modalities. On one hand, it's a combination of CT, computer tomography, to scan the body, to visualize organs, to see morphology, and on the other hand, the PET scan to see metabolism of the tumor, but also metabolism of the organs. And again, we need a radio tracer, which is something that is radioactively labeled, and this works in different fields. There's not only one type of radio tracer, there are more than 100 different ones that can bind to different biomolecules, to antibodies, to receptor, to anything that is inside of our target that we want to image inside the tumor that can be targeted by one of the radio tracers. And this is how the technology works. These are too many specifics, but basically a patient is inside a scanner room, and then there are hundreds and thousands of cameras around the patient who's moving through the camera ring, through the gantry. And while the patient is moving through there, we detect this radioactivity inside the body, which come from beta emission. We image the molecules, and with all these detections, we can input these into a computer model, and we can quantify, we can see where the tumor is and how the tumor behaves. Or in other words, basically the patient is on the red carpet and is being photographed by thousands of paparazzis. And if you take all these photos together, you get the best characterization of a person with all details and all details to characterize and to seek the tumor. How does this work in terms of, or what are the imaging properties that we can get from our PET-CT hybrid imaging? And you might know these images. Everyone with kids and children book might have seen one of these in Germany. They're called Wimmelbücher. And I think these are from a famous British author. And it's all in these images, it's all about seeking Waldo or Wally. Where is Wally? This is what CT can do, right? So you get a detailed image of your body. You get all details. You can see enormous amounts of different figures and persons in this image. But the question is, where's Waldo? So where's your target? And this can be difficult on CT because you get a lot of information that might also be unspecific for your tumor and for what you're looking for. This is where Waldo is. Without any additional help, can be difficult to find him. What PET does is that it adds, this is the CT image, again, you can see a lot of organs and details, but the question is, where is your pathology? What are you really looking for? What PET adds onto this is that it gives you a magnification, basically. It focuses your clinical question onto this one spot, especially here on Waldo, which is called Walter in Germany. And the PET images, they can magnify this one spot because they specifically they specifically seek this one person or this one pathology. The radioactivity goes in there and you get a very clear image. And if you combine both, you could get a nice image of the patient, but on this image, the PET really seeks your tumor and specifically highlights your pathology, and you're much more accurate and you're much more specific on your judgments on how to seek the tumor. How does this look like in clinical practice? So this is a patient example of a lymphoma. Lymphoma show a high glucose uptake. So you can see on the CT images, you can see a thoracic mass, but on the PET images, you can delineate those tumors much better. You can see the glucose uptake, you can measure it, but you can also see that most of the tumor is just intrathoracic. How does this work in terms of sarcoma imaging? Just an example of a 24-year-old patient with a neck tumor, and of course on MRI you can see the tumor in the neck, you can see extent, and you can diagnose it. And if you use PET, in addition to that, you get the molecular or metabolic information, and you get a much better delineation of the tumor, basically, and a higher certainty to localize it and to use these images for future treatment algorithms. So the question is there more to just imaging a tumor, more to just seeking the extent of disease that we can use these images and nuclear medicine images for? And one of the applications that it can be used for is to characterize the tumor, to use FDG PET for sarcoma grading. So going into the lobby inspired me to this slide. You might have seen the canaries and the parrots down there. So heterogeneity is one of the major issues and the major problems with sarcoma treatment, imaging and treatment. You can also call this diversity in this aspect, this biologic aspect. These are all birds. They may be from the same branch of birds, but they are all different, and they might also behave differently. They look differently, and this is a similar problem with sarcoma care. There are so many different types of tumors, and even for the same type of tumor, there are different grades and different behavior that you need to characterize in order to understand how to treat it and how to follow up a tumor. And this is just a common separation of the tumors into 3 different grades. So there's a low grade, intermediate grade, and high grade tumors, grade 1, 2, and 3. But it's difficult upfront if a tumor is diagnosed to understand upfront which of those grades of aggressiveness are inside the tumor, because tumors are very heterogeneous. They can be large, difficult to biopsy, and there's a certain uncertainty even with a biopsy workup to diagnose the aggressiveness of the tumor. So there's something like 10% mismatch or sampling error if you even analyze a part of the tumor and look for the aggressiveness. And this comes from the great heterogeneity and from the fact that you can only, for a biopsy or a partial resection, you can only look at parts of the tumor. And if you catch the wrong part of the tumor, as you can see here, there's a large tumor. Some of the aspects, they light up on PET-CT, so they are metabolically active. Some are not active. So these are different parts of the tumor, and depending on which part of the tumor you see, you might get a different viewpoint onto your tumor. Just similar with the canaries or the parrots, right? So if you have one feather, if you see a blue feather and you say it must be from a blue bird, you can be wrong, because there are blue and yellow birds, blue and red birds. So you need to capture most of the bird. You need to understand most of the bird to see which art and which branch you have in front of it. And PET-CT can help to characterize, to predict the sarcoma grade by looking at the tumor metabolism. And this is what we analyzed in one of these studies. So by making an image, a metabolic image of the tumor, we analyzed the uptake, the metabolism inside the whole tumor, but also the highest uptake that we can measure, the highest metabolism that we can measure. And we did this in 123 patients and tried to understand if this tumor is being resected afterwards. Is there a correlation between our imaging? Can we predict the aggressiveness of the tumor using these images and using the measurement of metabolism in those patients? And we saw interesting patterns. So at initial diagnosis, the metabolism is higher. At recurrence, the metabolism is lower, which is kind of understandable due to the treatment the tumor undergoes. It's being changed under treatment. But the central question still is there an association? And interestingly, there is. So, of course, more aggressive tumors, seen here as high-grade tumors, grade 2 and grade 3, they show a higher metabolism, they show a higher uptake on our PET images, so higher intensity of the images, and there's a significant difference. So if we perform metabolic imaging and there's a high uptake inside the tumor, we have a good information, a high likelihood that it is an aggressive tumor, behaves aggressively, and potentially needs more aggressive treatment. But we also found out that this only works at initial diagnosis. So if the patient has not undergone previous treatment, that might change our disease. At recurrence, the prediction does not work as well anymore. But at initial diagnosis, we can quite well predict the tumor grade. So FDG PET-CT is a predictor of tumor grade, which some fair accuracy. It is non-invasive, and it's just a form of initial imaging to seek the cancer, but also to characterize it in this way. And by calculating the type of accuracy, we can see around 80% sensitivity and 80% specificity to characterize the tumor, to predict high tumor grade, which can be very helpful in addition to other clinical workup to predict and to guide management and to predict the risk of patients. Is there more to imaging than just characterizing the tumor or seeking the tumor? Of course, we can repeat imaging and we can see if there's a response, if there's a change under treatment, and we can analyze what this change under treatment means. So FDG PET-CT can also be used for response monitoring of treatment. And this was analyzed in a prospective trial conducted in Los Angeles at the UCLA, where FDG PET-CT was used as an early survival predictor under treatment in patients who underwent neoadjuvant therapy, chemotherapy, for high-grade soft tissue sarcomas before the resection, before the local treatment was being performed. So these patients underwent PET-CT imaging before treatment was started, and then after 1 or 2 cycles of treatment, PET-CT was repeated to understand if the change on our PET images really can predict the further outcome of the patient, can predict the survival of a patient and the time until tumor disease progresses and grows again. And this worked quite well. So in the lower row, you can see the images or the survival plots for PET prediction. So if a patient had an early response, the metabolism went down by 26% or more. Under the first 1 or 2 cycles, the patient would have a high likelihood of a longer survival. So the curves separate here. Some of the patients who did not respond well showed an early progression or died earlier, and those patients who had a very good response in metabolic imaging had a longer survival. Same is true also for late response. So after the ending of the treatment, you can also see by changes in metabolism what you can predict the further outcome of the disease. This did not work out if we look at histopathologic response. So if we analyze the tumor tissue and see what does pathology say on changes of cells. And this did also not work if we look at computed tomography. So at the normal organ scans, the normal size criteria, which did not work in the system. So the question for us was, does this also work in a system where we add more aggressive local treatment, so hyperthermia as a local treatment in addition to systemic chemotherapy? Because hyperthermia changes the tumor under our treatment protocol, and the question is, does imaging still work in patients who get an additional local active treatment? So this is what we analyzed in 73 patients, and we wanted to find out if we perform a baseline PET-CT imaging in patients, then patients go into treatment, 4 cycles of treatment, and we monitor response after the 2nd, the 3rd, or the 4th cycle. Does outchange or response monitoring using PET-CT under a treatment scheme that includes chemotherapy and hyperthermia, does this still predict outcome in patients? The response was measured using PET-CT as partial response, so part of the tumor goes away, or complete response, which means the tumor completely disappears on the images. And this was also measured on CT. And of course, the outcome was the progression-free survival, so the time until tumor progresses or grows again. And this was analyzed separately for the local situation, so until the tumor itself comes back again, or the distant situation, so until metastases arise or until the tumor spreads to other organs. These were our relevant outcomes, endpoints for the patient. And what we can see is that on the upper row, these are the PET images. If we separate patients into our 4 groups by metabolic response, complete response, stable disease, complete response, partial response, stable disease, or progressive disease, these patients, after we measure response on imaging, they behave differently on the further outcome. So those patients with complete response and partial response, they show a much longer time after that, this imaging, until the tumor grows again and recurs. And patients, of course, with a metabolic progression have a much shorter time until the tumor recurs. So response monitoring using PET works. It worked for progression-free survival, but also for local events and also for the distant events. Also for our CT criteria, for change in size of the tumor, this also worked. So you can see the lower row is RECIST, the typical CT criteria. Also these criteria predicted the outcome of patients, were significantly associated with progression-free survival and time to a distant event, but not with time to a local event. And CT criteria were not independent, they were dependent on what we found on PET imaging. And this is because PET was more accurate. So if you look at patients who have no response according to RECIST criteria, so these patients did not show shrinkage of the tumor stays the same. And we separate these patients by PET imaging into metabolic responders and non-responders. We get an additional accuracy, but so in those patients who do not show any changes on CT or MRI, no changes to size, we can still predict, we can still see a subgroup of patients who will have a better outcome based on a good pattern on PET-CT, based on a good metabolic response, as compared to those patients who have a bad metabolic response. So PET is more accurate and stratifies patients at a higher accuracy and can also sub-stratify those patients who do not show any helpful pattern on CT in the system. Just to show 2 examples. So this is an example from a 70-year-old gentleman with liposarcoma. And you can see the images before starting of systemic treatment and the images after start, after chemotherapy, after the 2nd or 3rd cycle. And on this image, you can see by the color, you can see that metabolism goes down. So your SUV or your metabolic activity is being decreased under imaging, which is a good sign. So it's a metabolic responder. But on the CTs, we don't see that much change. The tumor still has fairly the same size. There's no response according to CT, but the outcome was favorable. The progression-free survival was much longer than the median of the cohort. So this patient had a good outcome of treatment, and this was predicted by FDG PET. So another example of a 51-year-old gentleman with a pleomorphic sarcoma. And here, similar situation. So this is of the lower extremity. You can see the tumor and those images. The color indicates that there's a high activity, high metabolism before start of treatment. The lower row shows situation after start of treatment. So the metabolism is being decreased heavily. So there's a very good metabolic response. And in line with this, the time until this tumor progressed again was much longer as compared to the normal cohort. So 37 months as compared to 15 months. On the right side, you can see the CT images, which were not really helpful because the change in size was just not there under treatment and was not predictive in this patient. So as a conclusion, for response monitoring, we can say FDG PET-CT works. We can predict outcome, relevant outcome, so time to progression or time until a patient deceased by early response and by late response, so under treatment and after treatment. And the change in metabolism was predictive of outcome, it predicted survival, and predicted time to progression after chemotherapy in patients with soft tissue sarcoma. The treatment response can also be conducted for a combined systemic treatment with regional hypothermia, so it's consistent, it's solid. And response criteria by size, by CT or MRI, were inferior in these systems. Metabolic response was just more accurate in these patients. So going from current potential applications to the future. So what could be the next step or next level for sarcoma care? How could nuclear medicine involve and potentially improve the outcomes in the future? So there's a very active field on research and clinical implementation on radioligands for combined application for imaging and for treatment. How does this work? You can see on the left side a tumor cell which has tumor-specific receptors or characteristics. So tumors on the tumor cell surface, you can see receptors which are only found in this tumor, which is in this case prostate cancer and PSMA. Nuclear medicine can design radioligands that bind like a magnet very tightly and very long to those receptors. The receptors are being taken up into the cell, they are stored there, and the radioactivity which is stored inside the cell can be used to either make an image of the tumor, which is the upper part of a patient you can see. You can make a very accurate image and see where is the tumor inside the body. But if you change this type of radioactivity, if you make it much harder, much more effective, you can also exactly treat those spots. So whatever is dark on this image is tumor, and whatever is dark on the lower image is radioactivity, which is therapeutic and is actively working on killing cancer and killing the tumor. The upper part is called, what you have just seen, positron emission tomography. We make an image of our cancer. And the lower part is called radioligand therapy. But it's the same medication, just using two different types of radiation inside a patient. Does this work? There are three systems, three diseases where this is part of clinical standard of care, where this is a very effective treatment option. Prostate cancer, by the end of 2020, we had a clinical approval and for a long time before availability of so-called PSMA radioligand therapy, so radioligands that bind to PSMA in prostate cancer, and that can be used to make an image, but also to treat patients with metastatic cancer. For neuroendocrine neoplasms, there's a somatostatin receptor which works very well. And we have clinical availability of radioligand therapy, the so-called peptide receptor radionuclide therapy, which is a clinical standard in patients with neuroendocrine tumors. And for thyroid disease, we have for more than 60 years now, for more than 80 years actually, as a standard #1 treatment, radioiodine imaging and treatment as the most effective cancer treatment which is available. How does this combination work? So it's called theranostic. It's a new term for it because we combine in one application treatment and imaging. We make a diagnostic and we make a therapy, theranostic. How does this practically work? So the upper part, the positron emission tomography, is an outpatient scan, right? So this can be outpatient appointments, consultation, preparation of treatment. And once the indication is made, the treatment, the lower row, is an inpatient treatment. So patients come in for a 2-day visit. They get an IV infusion of the treatment on day 1. Patients stay for 2 days on a radionuclide therapy ward because there's radioactivity involved that needs to be caught. And after 2 days, treatment is done, and patients come back after 2 to 3 months for the next cycle of treatment. So it's feasible, and the treatment algorithms are very well established for prostate cancer and for neuroendocrine tumors. And this is how it's being performed and will be performed in our center that you see here, which will open in Essen next year as a combined imaging and treatment center for cancer as part of the West German Cancer Center. What does this mean? So we have a target-specific combined PET imaging and radioligand therapy for certain tumor entities. Basically, what we do is what you see is what you treat. We make an image, we prepare the treatment, we individualize our treatment plan, and what we see on PET images is exactly what we treat afterwards. We can also use these images to calculate our treatment dose, to individualize our management plan. What's the outcome after these treatments? So patients live longer. These are approved treatments with a high efficacy. On the left side, you can see these are 2 New England Journal publications. On the left side, you can see the outcome of patients with neuroendocrine tumor who received this radioactive treatment. They showed a significantly longer progression-free survival under lutetium, this radioactive lutetium dotatate treatment, as compared to the normal hormonal treatment. On the right side, you can see the outcome in patients with metastatic prostate cancer who had a significantly longer progression-free survival and overall survival under PSMA radioligand therapy as compared to standard of care alone. So this principle is established and it works in 2 cancer entities. So the question is, how do we move further here for sarcoma? And I would like to take the help of a very intriguing person, which is Richard P. Feynman. He's a theoretical physicist, died sadly in 1988 due to progressive liposarcoma and the consequences. And he's a really brilliant, influential, and iconoclastic figure in his field. And fittingly, he also his research work was also based on what we see here in terms of methods, because he was working on subatomic physics and received the Nobel Prize 1965 for this work. What was his advice? Same equations have the same solutions. So why not trying the same principle in also other cancer entities? And this is exactly what we do for sarcoma. So we currently establish FAP-directed PET imaging and radioligand therapy to have a new entity of imaging and treatment in sarcoma. How does this work? It's the same principle. So the target here is FAP, so fibroblast activation protein, which is it's a characteristic, it's a protein on the cell surface of fibroblasts, of connective tissue. And this is highly expressed on this connective tissue around tumors, other tumors, but it's also highly expressed on certain sarcoma entities. For this target, researchers at the Heidelberg University, independent academic researchers, have designed several medications, several probes, which is called FABI46 in this case. And these can be loaded with radioactivity, either for imaging, which you can see in the upper row. We can make a gallium-68 PET image of a cancer, but it can also be loaded with highly active, efficient radioactivity like Y90, which has a high energy and is able to destroy and kill cells. Those are being applied intravenously, and depending on the application, we can either image cancer or sarcoma, or we can treat cancer or sarcoma using those radioligands. They're being taken up by the environment or by the sarcoma cell itself, and then the radioactivity induces DNA double-strand breaks at an amount which is lethal for the cancer cell. This is the principle behind it. And we are currently trying to translate and to approach this new principle. Why do we do this for sarcoma? Because in sarcoma, we have a very, very favorable situation for this type of treatment. On the left side, you see an example image of a histopathology of the so-called solitary fibrous tumor, the sarcoma entity, SFT. And everything which is brown on these images is our target, our FAP expression. We can see here, this is one of the few tumor entities where FAP is present on the tumor itself and on the surrounding cells of the so-called stroma. So our target, something that we want to hit, is really at high concentrations inside the tumor. On the right side, you can see as a comparison histopathology images and PET images of a patient with cholangiocarcinoma. And this target is also there. We can image the disease, as you can see on the arrow, but the target is only being expressed on the surrounding cells. So not the tumor itself, but the tumor surrounding stroma. The situation is less favorable. But for sarcoma, we have a very high target concentration, and we believe that this could be a fitting imaging modality and treatment to hit sarcoma entities for the future. So what did we look at? Of course, we want to understand, does imaging work for sarcoma? So what's the diagnostic accuracy of FAPI PET-CT in patients with sarcoma, and how does this compare to the current standard? So we compared the detection rate of new FAPI PET-CT to the standard FDG PET-CT in patients with sarcoma. These images were performed and offered either on the same day or on subsequent days, so there's no difference between PET-1 and PET-2. And what we found is that the new FAPI PET shows comparable detection characteristics. So we can see the same amount of tumor, the same number of lesions, the same tumor extent. So this could be a surrogate in the future to image sarcoma, but also to characterize the FAP expression in a patient without any invasive procedure. You can see that on a patient basis and on a region basis, we nearly had the same detection rates. And this was the same, was true for the primary tumor, but also for metastasis like the local lymph nodes, lung, bone, or other diseases. How are these tumors characterized if you look at the FAP expression level? And we substratified patients by the tumor grade, by the more aggressive and the less aggressive types of tumors. And we saw that, interestingly, in the high-grade sarcoma, so the more aggressive tumors that are more likely to metastasize and to show a higher velocity of tumor growth, they have a higher FAP expression level, which is even more favorable for a FAP-directed imaging and treatment, because those tumor types which are more aggressive, we can target these more efficiently because of a higher target expression level. So what was the next step? To look at the safety and efficacy of Y90, so the therapeutic radioligand therapy in patients with advanced sarcoma and other cancer entities. And together with our oncology colleagues at the West German Cancer Center, we implemented this in our clinical workflow. So for patients with metastatic sarcoma who have exhausted the standard treatment options, all the available treatment options we offered based on an individual decision after a FAP PET, the FAP directed radioligand therapy. And this was only offered, of course, to patients who had a very favorable and very good baseline imaging, so high uptake and a good situation, a good targetable tumor, basically. Of course, dosimetry was performed. Dosimetry is a type of measurement of radioactivity. So we want to find out if a treatment is being performed, where does the radioactivity go? Is there any organ that could take harm from the treatment? And this can be done by dosimetry, by characterizing the dose on each individual patient level. And this was being performed in these patients. The first dose was a lower dose rate performed with a higher safety just for low dose treatment and for dosimetry purposes. And once dosimetry confirmed feasibility of treatment individually, patients received higher doses, so the double dose basically after the first cycle. And a total of up to 4 cycles were performed in patients. These are images. Of course, it's theranostic, so each indication and each treatment is being followed by making images to it. The lower row is the Y90 scintigraphy or Bremsstrahl images, which really show how the treatment acts. So this is an image that is being performed under treatment. It shows the radioactivity that goes into the tumor and treats the tumor. In the upper row is FAP PET at baseline that needs to characterize and needs to make sure that all the tumor diseases and all the lesions can really be targeted by this new type of treatment. On the upper row, you can see for the different tumor entities, a lot of SFT have been included and chondrosarcoma. All of these entities were highly positive. And in the lower row, you can see that this positivity is also seen under treatment. So we give therapeutic amounts of radiation to the tumors, which is important to see. In total, 47 cycles of treatments have been performed in 21 patients in this initial assessment of the treatment. This is the second slide on patients that have been enrolled. Again, a quite extensive disease with local but also systemic disease. And our imaging under treatment was reassuring that we really also treat those tumors and that we give therapeutic amounts of radioactivity into the tumor and into the metastasis because these really show uptake. What were our results? We look at disease control rate. So we want to find out how many patients have at least stable disease, partial response or complete response. Disease control rate under treatment was 65%, and disease control rate after treatment, after finishing the treatment and scanning after 3 to 6 months was 50% under this treatment. Under treatment, there were 3 patients with a partial response with a shrinkage of tumor, and at the end of treatment, there was 1 patient with partial response and shrinkage of treatment using the CT or MRI criteria. This is response by both the size of the tumor and using PERCIST, so metabolic response criteria. So there is some signal, there are some signals of efficacy, and for us, looking into the patient cohort was reassuring also for how to further proceed with translation of this new treatment, is that most of the patients who had partial response or disease stabilization, they were patients with sarcoma. So this is really an entity where this treatment can contribute potentially in the future. I have to add to this that all the patients had progressive disease when they came into the treatment. So there was no stable disease, but all patients were progressive, and any stabilization or partial response could be called a sign of efficacy of this treatment. The question is, if we measure response, does this really translate into a longer outcome, or is this associated with a longer outcome? And of course, we also looked into survival of the patients. I wanted to know if we see response on imaging, does this associate with the survival afterwards? And there was a significant association. So patients who were stable under the treatment had longer overall survival as compared to patients who were progressive under treatment or where response could not be measured because of a very rapid progression of disease. I just want to show some examples on how the treatment algorithm could work and how this was implemented. On the left side, you can see a patient with 55-year-old patient with fibrosarcoma, and then we do baseline imaging to reassure that the tumor can be treated. You can see dark spots where the tumor is, so a very high target expression level, which is good for us to be able to treat it. Then after consent, we made a plan for 4 cycles of treatment. Then you can see under each cycle of treatment, there's imaging being performed, there's dosimetry being performed to make sure that there is no harm, but we apply therapeutic amounts of radiation and the treatment works out. And this was the result. We saw after 2 to 3 months under treatment, we saw a shrinkage of the tumor inside the abdomen. So the tumor was smaller and also the metabolism went down. This was one of the patients with partial response under the radioligand or the FAP-directed radioligand therapy. What's about the adverse events, so the side effects that we would see under treatment? And the right side of this table are the side effects which are severe, so the ones that need to be treated, the ones that need adaptation of the treatment protocol. And then in only 4 patients, we saw potentially related grade 3 or higher adverse events, which would be lower levels of platelets or lower levels of leukocytes, that triggered us to adapt the treatment protocol. So in general, the vast majority of patients did not have severe side effects under treatment, which was also reassuring. This could be a potential treatment and to continue translation of this treatment for the future. So what's the outlook for this treatment? So we saw in 47 radioligand therapy cycles in 21 patients that have really extensive disease, metastatic disease, and which also was progressive, that we have seen signs of efficacy with potential shrinkage of tumor. We have seen very few serious adverse events, so very few side effects that needed attention and treatment in 4 patients under radioligand therapy. There was a partial response, so partial shrinkage of the tumor in 18% of patients and a disease stabilization in 47% of patients under treatment. So majority had signs of efficacy under treatment, and this also kind of associated with a long-term outcome, so a longer overall survival. So of course, this is a translational aspect. We've seen that there is favorable aspects for safety and efficacy of this treatment, but of course, we need improvement of the treatment protocol. We need higher efficacy of type of radiation for sarcoma, but of course, we also need prospective investigation and prospective interventional trials to really go the next step and the definitive step to translate this new type of imaging and treatment for patients and for patient availability. And of course, for this, funding is critical to make this happen in a rare disease. It's critical to get IIT funding and support to go the next step. And with this, thank you very much for your attention. I'm looking forward to the discussion, and of course, my acknowledgement to all the colleagues also on site who made this this research possible to translate new forms of imaging and treatment for patients with sarcoma. Thank you very much.
So, thank you very much, Professor Wendler, for this really fantastic talk. I think that makes really clear that we are now moving with this kind of technology, with this kind of knowledge into other options. Because historically, we always looked to systemic treatment. So we look to drugs, but this is a very interesting option, maybe for the future. Also in sarcomas, we have seen results in other indications or in other diseases. Maybe just the first question, when we look, because some of the people in the room have never seen maybe a PET, and maybe you can just explain the basic principle in the PET, why it works. So, for example, my body loves sugar, unfortunately. And this sounds that the tumor loves more sugar or is keen, very hot to sugar, and that's why we can see it. Is this the action?
That's the case. So the tumor shows as a specific characteristic a much higher sugar uptake. So if we use this radioactive sugar, it's injected within this imaging procedure, which takes about 1 hour. The tumor is just much faster on taking this radioactivity up. And then if you make an image of it, we can see it lighting up on the images because there's a higher radioactivity concentration inside the tumor. And this has to do with the tunnels that take up sugar, because the tumors have a higher amount of sugar tunnels to really include this into the tumor itself. Tumor is very complex, but one of the aspects is really taking up sugar and making sure that there's enough metabolism to grow.
And when you look to this image, you get the impression that everywhere is tumor. And we have seen some areas like brain or heart or different other areas. This means not that there is tumor, because they have a specific uptake in sugar, as I understood.
So for the FDG PET, it's more complex. So there are organs who just would always be seen, which is the brain and liver and spleen, because they have a natural sugar uptake. And depending on metabolism, it can also be somewhere else. But these we kind of distinguish. If we look at the images, we can see where the organs are, we can sort them out. And everything which lights up on top of this and shows inside the images, which would not be expected. And then this is the area where we diagnose the tumors.
Okay. So next question, yeah.
I have two questions, actually. The first one, going back to the data, I think it was slide 49, I can't remember, but looking at progression-free survival and stable disease, what was the measurement? Because it looked like from standard of care to on your chart, and you may have looked at it longer, it's just not reflected, it was 5 months. So can you clarify that? Like, what was the measurement in terms of, how many months your data showed? And then the second question I have is the long-term implications, because we know we can only have so much radiation, right? And so the future of what happens if ultimately this doesn't work for a patient, are there future implications in terms of treatment options?
Absolutely. So in terms of timeline, for the PET images we have seen, for the FDG PET predicting response, the timeline was around 5 years for each patient. So quite a long timeline with a typical follow-up intervals of 3 to 6 months imaging in a patient. So this is the interval where each individual patient was followed up on. On the FDG PET metabolic response analysis was really a long follow-up. For the treatment patients, so the most recent slides you have seen, the FAP-directed radioligand therapy, it was a much shorter time interval. I think it was 12 months to follow the entire cohort because there was a much higher velocity of progression. So within those 12 months, we already had a lot of progressive or overall survival events where patients died under our follow-up. This is to look at the follow-up intervals, and it was all in the typical oncology intervals of 3 to 6 months per patient. So the question is, what do we do if patients don't respond enough? What we see in our current radioligand therapy is that we get efficacious treatment. We can shrink the tumor, but of course it's not curating patients. So we will reach at some point a level where the tumor might not respond as well anymore, might come back and needs different treatment. The radioligand therapy is a totally different kind of treatment as compared to what is out there currently. For sarcoma, for example, this would be a new type of treatment not available currently. So it's acting with internal radiation, and all the conventional treatments are through conventional chemotherapy, drugs destroying the tumor, or with immunotherapy. So it's very compatible to other treatments. Usually, what we see with our previous treatments is that patients can get a chemotherapy before they go into radioligand therapy, then they are under radioligand therapy, and if the tumor progresses, they can go back to chemotherapy again, or they can go back to other medical types of treatments without seeing any adverse events or side effects. So it's a very compatible type of treatment because it works totally different than what was done before or not. The question for us is, how can we raise this to a higher efficacy? How can we improve it to make sure that more patients respond? And this is where scientifically, we are not yet at a point where we can really address this, but there are a lot of concepts on how this could work, like combination treatment. So if we combine an internal radiation together with a medication that stops repairing the cells, so stops the tumor by repairing itself, we can be much more efficacious. So inducing double-strand breaks and then inhibiting repairing double-strand breaks can be much more efficacious in the future. Or combining our internal radiation, radioligand therapy, with immunotherapy could also be a potential field where we can boost the efficacy in the future and make it much more efficacious. But this is currently under phase 2 trials in prostate cancer, neuroendocrine tumors, and if this kind of works, it will also go to other fields and make it potentially much more efficacious.
So this relates to to GIST patients. So we've had patients who've responded well to Y90, and there are times where there's a really bad infection that they have to fight after the procedure, and it just abscesses and it gets really bad, and it's sort of like a downward spiral. Is there a way that you could screen for patients to prevent those type of infections from happening? Sometimes they might have had successful Y90 in the past, so I don't know if like there's damage previously in the liver that might be causing the infections. So I was just wondering how you would address that.
So that's a good point, and then a very important point for treatment planning. Just to clarify, what you mean is a Y90 treatment of the liver, as you mentioned, so a radioembolization treatment. So there are tumors inside the liver, and then we give radioactivity, is also a nuclear medicine treatment inside the liver to treat these, it's small spheres, basically, small like sand spheres that go inside the tumor and then treat it. And what is most important is really treatment planning for this procedure. So to make sure that the liver and the patient has no risk factors for infection afterwards. And what is especially important for radiating the liver using a Y90 treatment is that there's no material in it. So if there's a stent or any other material, any shunt material in it, we know that there's a much higher likelihood of infection of these materials inside. And in these patients, we would go in and give antibiotics just to prevent any infection. This is the way we try to account for, or where we try to control these infectious events, which are very unfortunate, can be very difficult to treat. By calculating the risk upfront, is there any source of inflammation in a patient? Is there any material, which is most important? So any stent, any plastic or metal material inside? And then we would preventively give antibiotics to prevent any superinfection of the treatment. For radioligand therapy, it's not so much the case, because this really treats the whole body, not only the liver, and there are no infection events yet known also for the other treatments yet.
Congratulations, that was a wonderful presentation, and thank you.
Thank you.
I love the confidence that you all have in creating a theranostic centre. But tell me, how many patients overall in a year of whatever kind of cancer would you expect to treat in such a centre? Are you aware of any other similar centres being developed in other countries? And could you expand a little more on the skills and professionalism that has to come in behind you as a medical doctor in order to make it all happen? Because clearly you can have a cyclotron there, or one or more cyclotrons. You're going to have chemical laboratories for the manufacture of ligands, etc. Create me more of a picture of what's involved in theranostic centers.
Absolutely. So this is a very important question for us also. So looking back 20 years ago, our field, nuclear medicine, was radioiodine treatment and thyroid treatment. And this is exactly the new aspect that you mentioned here. So this all builds onto a strong nuclear medicine infrastructure. We have new types of treatment now, which are PET imaging and radioligand therapy for several types of tumors. And for this, you need a strong infrastructure, which includes a radiopharmacy on site, so a pharmacy that can handle these radioactivities. A cyclotron, some of the sites, not everyone, but some of the sites, having a strong nuclear medicine program on site, a nuclear medicine clinic with nuclear medicine physicians on site who can really handle these patients, can handle them clinically, to do follow-up, do treatment planning, do dosimetry planning. And then having the PET-CT scanners and the inpatient treatment wards. So I think this is the critical part. So having a full-scale nuclear medicine clinic with inpatient and outpatient procedure, and this will be able to handle all these types of treatments that you have just seen. So the question is, what is the current situation? In Germany, there are more theranostic centers and more theranostic clinics available. So we have more than, I would say, 20 academic centers who have inpatient treatment, PET and cyclotron, and radiopharmacy, and then outpatient clinics, another 20 to 30. In other countries have started to decrease this infrastructure, because it was kind of felt like it's not so much needed anymore before radioligand therapy came around. So I think the critical aspect here would be to really uphold a strong nuclear medicine clinic that can apply all these treatments in the future. In which volume are we looking at? So if we look at prostate cancer, we look at 10,000s of treatments in the future to come. We have not yet caught all the entire volume yet, because the approval was just done by the end of last year, and it's now going through kind of reimbursement procedures. But from the epidemiology, there will be 10,000s of treatments in the future. So all those centers who are currently available will be very busy to offer the treatment, the radioactive treatment, which is a very specialized one. And potentially regions, not only Germany, but also other countries, might need more centers in the future to really follow this infrastructure, to really offer this. And I think that's the most critical aspect, is really a dedicated nuclear medicine / theranostic unit with the whole education and with a full radiopharmacy on site, and then they will be able to do it.
Thank you. You're opening up a vision of something which I think is, I hope it will happen, because I think it's very, very important. So thank you. I buy the vision.
Thank you very much. For us, it's coming with the success of treatment. So we're not trying to sell anything. We have medications that are just much better than other ones. So patients are coming in and treatments are coming in, and that's the wonderful part, because it just works. And then if there's a challenge to get this as a service to patients and to get the volume done, I think we need to face the challenge and just increase the load and get more education to physicians potentially.
We have a saying in English, the proof of the pudding is in the eating.
Hello.
Sure.
I want to ask you about the stereotactic body radiotherapy for liver metastasis.
But the radiotherapy for renal?
Stereotactic body radiotherapy for liver metastasis.
For metastasis in general, or for
okay. Liver metastasis.
Liver metastasis, stereotactic radiotherapy for liver metastasis.
Yes.
So the stereotactic radiotherapy is really a type of external radiotherapy, right? So someone goes in with an external beam radiotherapy into metastasis, and the stereotactic, so it's not so that much of my field, but what I can say about the stereotactic radiotherapy of metastasis in general, but also the liver, is that if these are few metastases which are localized, a stereotactic radiotherapy can work very well and can be a good addition to efficacy of a treatment, but only if they are controlled. If the disease is at several spots inside the body, it's usually very difficult to do an external radiation, because the external radiation can only catch whatever is inside this one field, which is very different to systemic treatments or this internal radiation, which acts everywhere inside the body. So stereotactic radiotherapy of few, so 1 or 2 liver metastases, can be an efficacious treatment. And if it's well prepared with imaging, the same for liver, but also for bone metastasis, for example. If it's only few spots, less than 3, it can be an efficacious option.
Thank you very much.
Welcome.
Okay, so thank you very much, Professor Fendler. I think that was extremely helpful. You just mentioned it, to have maybe a new vision also for the sarcoma community. And maybe just to close the circle, you just mentioned at the end of your presentation IIT. And this is exactly where we are going, as you understood with the NCT, that we really have capacities now in the future to have such innovations and bring such innovations really to the patient. That's the idea of the NCT, that on one side you have brilliant researchers with good ideas and good concepts, and then we need to take these ideas and need to concepts and bring them as early and soon as possible into to the patient. So thank you very much.